So we do begin with day 2 proceedings, and the first part is case presentation with the masters. This is presentation by invitation, and our first speaker today is Dr. Parajani. Sir, can I request you to come here? The chairpersons for today's session, Dr. David Cumberland, Dr. Ashwin Mehta, and Dr. Fazila. I can see them on the stage, and can I request Dr. Samir Dani, Dr. Ganguly, Skant Trivedi, Dr. Dharmesh Solanki, and Shilpesh Champaneria to come on the stage. All yours.
Good morning, Dr. Cumberland, Dr. Ashwin Mehta, Dr. Hiramat, and the other distinguished masters on the panel. Just to give you a little brief history on this patient, his patient is about 58 years, middle-aged man, diabetic and hypercholesterolemic, and he had history of frequent TIAs and lasting for a few minutes in about a month's time before he consulted our neurointerventional colleague. And he got his MRI done, and he found a very critical left internal carotid artery obstruction. So he was scheduled for the procedure of carotid stenting in our hospital. But while he was in the hospital, he had some chest pain. And then they went into the history because the patient was not admitted under me and was referred to me, and we took a history. That about 3 years before he got the TIAs, he had severe chest pain, acute coronary syndrome-like picture, and he had changes in the L2, L3, and ABF when we looked back at his ECGs at that time. So I told him that before you do the carotid angiogram, let us do a coronary angio. And so we started with the procedure of coronary angio. And you can see this is the right coronary artery. The left coronary artery appeared normal, and it was giving collaterals to the right coronary artery through the posterior descending. And the right coronary artery was chronically totally occluded, but I did feel that there was some channel inside, microchannel. Doesn't run. Yeah, okay, sorry. I did feel that there was some micro channel inside. And while we did this, you can see there is some evidence that there might be some micro channel there. And this is the left system. And this is the carotid angiogram, which was done on the DSA. You can see this is a very tight, critical internal carotid artery obstruction with an ulceration there. And so the question came at that time, discussion, what we should do. This was like a clinical discussion between the cardiology team and the neuro-interventional team, what we should do. Should they go ahead, since there was a history of frequent TIAs in a very short period of 2 months' time, and the inferior wall changes were demonstrated or evident about 3 years back. This looked like a CTO. What we should do. Should we go ahead, neurologists should go ahead and do the carotid stenting, or should we open up the right coronary artery? I think I would like to have the opinion from the panel.
What do the panel think? Any burning comments?
Patient is already on the table. The entire family was ready to get the carotid angioplasty done, stenting done.
Yes, as the patient is having both carotid and the coronary disease, so I shall try to tackle the coronary first and then go for the carotid.
Can I just ask, he'd had recent chest pain, had he? He'd had some recent episodes of chest
Yeah,
pain.
a day before. You see, the patient got admitted a day before, and at night, he just complained that following meals, it was like a postprandial substernal discomfort. And of course, there were no EKG changes at that time.
Okay.
The nurses did take the EKG, but then to the neurologist or the neurointerventionalist, it looked like a classical substernal pain of angina. And I must give him credit that being a neurointerventionalist, that he did sort of identify that as a coronary pain. That's why it made a reference to me.
Right.
Ashwin, what would you do? Sorry, go ahead.
I will also agree.
Patient
with
is
the-
on the table now.
We can tackle both the lesions simultaneously. If the right coronary can be successfully angioplasty, then at the same time we can do a carotid on the same sitting.
So which one you will attempt first?
Right-
the
right
coronary,
right
CTO,
coronary.
or you
CTO,
will do the
CTO.
carotid stenting first?
CTO first.
CTO first.
No, I think I would do carotid first. I feel this way, that this is a fairly collateralized vessel, and the chances of muscle necrosis is not really very high. And just in case you end up with complication of hypotension, which I think is not uncommon, or let's say one should be prepared that there could be a perforation. In a CTO is one subset where perforation is far more common than any other situation, and at that time a hypotension and could precipitate a stroke. And considering that this is a long-standing total occlusion, maybe exacerbation of late, but a collateralized vessel, my feeling is that I would attempt carotid first, which I think is comparatively a shorter procedure and could be quite comfortably, successfully accomplished. And then one could go ahead and attempt right coronary. That's how I would feel. Fazilia?
Yeah, well, here we've got an interesting situation. This patient has two complaints. He's having TIAs, and for that TIAs, it's causing him considerable distress, and he has already consulted the interventional neurologist. Now, on top of that, he's having something of a chest pain. So have we evaluated, is it troponin positive? What's the intensity of the pain? I would go by the intensity of his symptoms. He's got chest pains, and he's also got TIA.
Thanks. Yeah, that's a good point. I think if he was troponin positive and in the throes of an acute coronary syndrome, that would be a different matter. But I agree with Ashwin. I don't see the urgency for doing a chronic coronary occlusion, and I agree with him. You know, you don't want to be entering into trying a chronic occlusion, which may be a prolonged procedure. I agree with him. I think the priority is the carotid, and then you can address the long-standing occlusion at leisure, really. You don't need to think about it at this moment.
I think technically the carotid appears much simpler and as compared to the RCA, and it is quite likely that if there is a complication of RCA, like hypotension, this lesion is going to give rise to a stroke on the table.
Yeah, I think I agree with Ashwin that since the presenting symptom of this particular patient was TIA, and as you know, if he would have developed a hemiplegia, that would have been totally unforgiving. And his pain was definitely very typical. The troponins were negative. EKG did not show much of changes. So he was like, even if he was an acute coronary syndrome, he was like a low risk acute coronary syndrome. Plus, the right coronary artery is well collateralized, and since over 3 years old chronic CTO. So I personally felt that the neurointerventionalist could go ahead and do the carotid stenting. But to my surprise, for a change, the neurointerventionalist said, I don't want to do the procedure first, because he said that he has seen several times when of course we all have seen, we all do carotids, and we have seen bradycardia, hypotension developing. So he was a little concerned that patient having a right coronary artery lesion, which starts right from the origin and somewhere around the sinus nodal branch, if you saw the angiogram, he was really worried that it might cause him more bradycardia. I told him also that we can put in a pacing wire, which in any case we put in. But he was not convinced, so he requested me that I should go ahead and do the right coronary artery first. I told him that this is a CTO, we may still not succeed. And then you might have to take the patient in any case for a neuro. He said, okay, give it a try and we will see. So surprisingly, the one guy who should have done the intervention first, he asked me to do the intervention first. So anyway, we went ahead right at that time. Patient came for one procedure. He came for the head. We went to the heart. Okay, so this is how we started. And first, I thought since there was a micro channel, I took a coated wire. I think this is a Fielder wire. We tried Fielder wire several times. Would not cross. Then we took fine cross. Even then, we were unsuccessful. Then I took the choice PT. That also would not cross. And then ultimately I decided to go on the more sort of a heavier wires. And we started with Miracle Brothers 3. 3 did not go. Then ultimately 6 went through the CTO. And the problem did not stop there. No balloon would go. I thought that now since I had crossed, I took in a 2 millimeter sprint balloon, would not cross, came down to 1.5. That wouldn't cross. 1.25 did not cross despite jackhammering. And ultimately 1.2 mini track went down. The message I want to give that different smaller size balloons have got a different crossing profile and different kind of a strength. So don't give up. That once your wire has gone in, then of course you've got tonus to go down. But don't give up on the balloons. Go on undersizing the balloon and cross. Ultimately 1.2 went down. And once we opened it up, then it was no big deal. And then we put in a micro catheter, exchanged the wire, and kept on stenting right from the place below the acute margin, right up to the ostium of the right coronary, put in 3 stents there, and gave him a perfectly open up right coronary artery. And then after 3 days, our neurointerventional guys took him for the carotid stenting. And did the carotid stenting. You can see that they put in a spider there as a filter wire. And they got a very decent opening there. So the message that I want to give, that sometimes you will come across both the diseases in the carotids as well as, which is in about 20% patients, you see a carotid disease along with the coronary artery disease. Prudently, I felt that it is better in a situation like this to do the carotid first, because the patient's presenting symptoms were TIA. But you will come across a very cooperative neurointerventionalist who will ask you to do the coronary first, and then he will take over the patient. Thank you very much.
Very nice, thanks. Very, very interesting. And good that it ended well. We have two other presenters, Dr.
Yes.
Palajani, is it?
Yeah, right. David, I think there's slight change.
Okay.
Case number 3, Dr. Narayan Gadkar would be presenting next now.
Because we have a few minutes time, then I would like to just have a comment on this. The neurointerventionist was very much concerned about the bradycardia, and because of which we took the patient. And I don't think this is the ideal condition. There are ways to prevent the bradycardia. Definitely, we put a temporary pacemaker for that. But the other way is to just give atropine before inflation. And that is a very good way to prevent this. And we can make them understand this, that there is nothing to concern about that. You should not go first, because the carotid was the more of concern, and that must have been tackled first by convincing the neurologist, or if you can do both the intervention.
So
I think you start with the carotid and then go to his.
This is already
bradycardia.
discussed.
Yes.
It's already discussed that carotid should be done first. Dr. Palajani himself said that he was, but I think they were in the same hospital next to each other. So it's okay. Narayan, 7 minutes.
Good morning, everybody. I thank CAD organization for giving me this opportunity. My presentation is not particularly a case presentation. It is about a technique for transradial procedures and using sheathless techniques. As we all know, means radial procedures have been accepted, and now more and more people are going for radials. As means it is more comfortable. I don't have to go into the details. Regarding sheathless procedure, the term itself defines itself that you don't have to use a sheath. I know all that intervention started with sheathless in the femoral, and then the sheath were devised because of the bleeding complications in the groin area because of not using a sheath. But if you ask me, I feel radial is a different reason why sheathless has to be used. As compared to femoral, the dead space in the radial artery, between the radial artery and the skin, is not much. So the chances of having hematoma and all in the radial is less. And secondly, most importantly, why sheathless means decreasing the profile size is important in radial, because radial being a small artery, chances of it getting occluded post-procedure, and there is enough data to show that the smaller the French size of the catheter used, the better it is. That is precisely the reason why I thought about this concept, because post-angiogram, a lot of our patients used to lose pulses, and subsequently when we needed to do an intervention, we didn't have the radial pulse. So that is what, since more and more people are doing radial, today we are talking about the radial technique, how to go about, how to do it. But I feel 10 years from now, there will be a huge debate and data and a discussion on how to preserve radials. So future back to femoral, we'll have to do back to femoral, because one of the important reasons will be loss of radial pulse. And this is enough data, and I will not go into the details of data, that adequate heparinization using 5,000 heparin in an angiogram instead of 3,000 reduces radial artery occlusion post-procedure. And patent hemostasis is a technique wherein you occlude it is a compression technique wherein you give that much pressure just to occlude the artery to prevent bleeding, not to over-occlude, so that there is loss of radial pulse later on. And lower the profile, lesser the chances of post-procedure radial artery occlusion. And we all know Indian radial artery diameters are lesser than the Westerners. We use a lot of reused material. So chances of post-procedure radial artery occlusions are higher as compared to what data says in the West. And the concept of sheathless means I don't have to explain this. You don't use an introducer sheath, so it decreases the diameter. So when you use a catheter, diagnostic catheter directly, instead of using a sheath with a catheter, it decreases your downsize. It is like a 3 French system. It makes it a virtual 3 French system. This is, I feel everybody needs to see it, how it is done. It is not a very difficult technique. You just, what we have to do, instead of a pink needle, or 20 French, you use an 18 gauge needle to puncture. That is the only change you have to do. And once you have the puncture and the blood flowing, you use the radial wire to and cannulate the cannula over the radial wire. And then you can give your whatever cocktails you need to give. And through this cannula, 18 number cannula, you use the 3-5 wire directly into the radial artery. That is the only thing. Just upsizing it with a green, means 18 number cannula, is the only thing which is required. And once your 3-5 wire goes, you give some local around it. And what is most important is to give a good nick. Means it should not be too big so that you have pericatheter ooze, or it should not be too small. The entry of the catheter into the skin is the most important thing, and the radial artery can always be stretched by the catheter, and this is how easily it goes. This is a 5 French Tiger catheter, which goes as easy as this is. And then you can finish the procedure. And the rest of the things is I don't have to elaborate. The advantage is it is a minimal invasive procedure. Smaller hole reduces the occurrence of radial artery occlusion, and effective for small vessels, especially in those short females, 5.1 and all, 5.1 feet females. And when you introduce a sheath, it is bound to cause pain because the radial arteries are not very big. And sheath-induced pain spasm, I have realized that it is less. Radial artery occlusion rate was also less. And cost of the procedure in Indian countries where economics are very important, sheath itself causes this thing. It costs around 1,200 rupees. You save on the sheath cost, and you increase the size, length of the catheter. So renal angiograms at times become very difficult from radial arteries. You gain on 1.5 centimeters length of the. So we did our studies using a sheath and sheathless procedure, and we have realized that radial artery occlusion rates were lesser using a 5 French sheath. So that excited me and made me more excited, and I thought, why not doing a 4 French system? And 4 French makes it all the more beautiful. And 4 French, the outer diameter being 1.35 centimeters, and it can be claimed that 4 French sheathless procedure can be the most minimal invasive angiography ever known. And radial artery occlusion rates are relatively very, you don't see radial artery occlusions with 4 French catheter. This article in Indian Heart Journal had come, 4 French as the most minimal invasive angiography 3-4 months back. And I use a JL catheter now. I have done more than 300-400 cases of late. Wherever I get the 4 French catheter and the 18 number, I manage to do with the 4 French angiogram using 4 French. You just need to modify your JL catheter like a Tiger, and you can make it more obtuse, somewhere between JR and Tiger. So your angiogram becomes, see, you can see this angiogram using a 4 French, opacification, everything is perfect. And especially for this right, where you have ostial lesions and all, your chances of dissection and complication, deep throating of the Tiger is very high. And this JL catheter behaves like a JL and JR. And the advantages of this 4 French JL is definite reduction in the incidence of spasm. So for people who want to learn radials, you can maneuver this 4 French catheter for a longer time as compared to a Tiger. So for learners also it is good. It will not cause. And radial tortuosities, Tiger tip being a big, negotiating radial bends and all are very difficult at times with Tiger. So JL helps in that. Pressure damping, Tiger enters the conal arteries and there is pressure damp and all those things. So these things are also taken care of. Deep intubation of RCAs with JL is not seen when you modify it. And catheter-induced dissection, that is a fear for learners, that Tiger deep throats and all. With this modification, you generally don't see. You will fail, but you will not complicate. The only thing you have to take care is you can kink the catheter if you are too vigorous with your torquing. And second thing is when you try to pull out a 3-5 wire very fast, you can suck in air. That also can be modified by using, see, if a company comes with a sidole of JL, that problem also will be solved. Your suction and your opacification will be much better. I have done that also. I used to just do sidoles in this JL just to see the opacifications. And when you use sidoles, make sidoles in this JL, it is as good as any other angiograms. It is safe? Absolutely. Feasible. This EuroPCR, I presented this data of doing sheathless radial angiogram, and it was very well appreciated. Now extrapolating it to angioplasties, this sheathless 6 French catheters can also be introduced using a mother-daughter 4 French catheter inside. a longer 4 French pigtail diagnostic or a 4 French multi-purpose, which is 120 centimeters length, you insert in. So I will show you with the 7 French catheter. This is UCath. With this same concept, Asahi has come with this UCath catheter, the concept being the same. I am a slightly faster because I have a limited time. Yeah. So now limitation of radial is a 7 French sheath. 7 French sheath cannot be easily introduced into the radial artery, as we all know. So this is a mother-daughter technique wherein a 5 French and a 7 French, 5 French diagnostic and 7 French. If you see the mother-daughter technique wherein over the 3-5 wire, the 5 French catheter acts like a dilator and through only last 30-40 seconds. And this is how we have done 7 French procedures using a sheathless technique. And this is how it looks inside, the 3-5 wire, the multi-purpose, and 7 French guide. And you can do this bifurcation simultaneously with ease. I know it can be done with 6 French also, but the comfort given by a 7 French catheter cannot be matched by a 6 French catheter. So all these rotablations requiring 7 French catheters, and especially these palmy situations wherein you need 7 French suction catheters, just because you convert into femoral, just because a 7 French sheath is difficult. But with this technique, you can directly insert a 7 French guiding and do palmies requiring 7 French suction catheters. So in conclusion, I feel sheathless transradial procedures are absolutely safe and feasible. If a guy like me can do, anybody can do it. And it carries the potential. I feel 4 French angiogram should be the way everybody should, because it is one of the most finest and the most sophisticated. Means patients don't realize what has been done. It is as good as that. Thank you very much.
Very good. I'm sorry, there's no time for direct to the speaker. You better talk to him. Just one little one. Which company gives you all this equipment?
Pardon, sir?
Which company gives you all this equipment? Where do you get it from?
Catheter?
Yeah, the catheters.
See, 4 French Judkins is a normal catheter. You just have to shape it before introducing.
Yeah, okay.
You just need to shape it, make it obtuse, somewhere between JR and Tiger.
Okay.
And
okay. Thanks. That's great. Thank you. Who's next? Do you know who's next? Is that it?
Thank you.
Yeah, okay. Thanks very much. I think it's time we moved on. Is Dr. Kalmath here? Okay, thanks. We're a bit short of time because there is a live transmission coming up, I think. And clearly we need to honour the schedule.
Good morning, Chair, and good morning, friends. I just wanted to show you, like in this forum, we need to really ask the experts. So I brought a case wherein we're doing a radial angioplasty in an elderly gentleman of 73 years. Next slide, please. He was 71 years old with a history of hypertension and not a smoker. Presented with very increasing angina last 8 to 15 days. And echo functions were all right. And angiogram revealed a proximal calcified lesion, which you'll see. Next slide. Just run that. Just run the slow. It looked like, no, run the show. Yeah, click that. It looked like a simple proximal LAD lesion, which just click there. Wherein we thought it should be a routine angioplasty, so we are taking this right radial route actually. And yeah, you can run this also. You can run this. Just click. Just click that. No, go back. Click that. Just run the movie. So he had a moderately calcified lesion. So I just wanted to show you that what would the you can run that. No, the previous. Who's there, Elish? Run that movie. Run it, just run it. Yogesh. No, we just played it just now, a minute back, sir. Just the left click runs that. So you could now see a fluoroscopic calcification there. And on that, I could ask the panel that I want to show you the film and ask you, what would be your line of approach before starting out the angioplasty? Because at the outset, I could tell we did not have rotablation there in the setup. So
you've got a calcified proximal LAD lesion,
That's right,
and you're just saying,
Cumberland.
well, does anybody have any particular strategy for?
Yes, sir.
Is it very heavy calcium? I mean, you can see.
Yes.
You can see it,
He did have a fluoroscopic calcification.
Yeah.
Yeah.
Oh, there we
Freeze
are.
that. Thank God. Freeze it. Just run it and click immediately. It'll freeze it. Freeze that. Freeze it. Yeah. Could you see that right there in the proximal LAD and ostial LAD? Just run it now. No, previous shot. Yeah. Just run it. Yeah. Freeze that. Yeah. Dr. Mehta, sir, what would it be? Because it looked like a very eccentric calcified lesion.
Yeah, it is. There are two problems. You said to me that if rotablation is not available on the spot for you, how would you go about?
Yes.
You know, there will be two problems. A calcified lesion is resistant. It does not open very easily at even higher balloon pressure, and the balloon ruptures are common. And the second issue is that the delivery of hardware is difficult, because once the wire is biased towards the calcified area, then the stent struts abut against it, and the stent does not move forward. So these two issues would be in my mind.
I think you read the film very well without seeing it. I'll show you. That's what happened, sir. Next slide. I thought at least we'll have at least we'll have a poor man's cutting balloon. I put two wires, one to protect the diagonal, large diagonal, and also act like some sort of a cutting balloon. Like we didn't even have cutting balloon off late. Go next slide, please. So, this is what I did. Next. Yeah, it was like with the 3O balloon, it was opening up a little bit. The lesion looked as if it was debulked to almost 80% of that. Next slide. Yeah, freeze that. No. Yeah, freeze. This is what I got a result. As Dr. Mehta very clearly told me that the biggest problem in calcified lesions is, and especially the guide support was not great, but still okay. Next slide. Yeah, freeze that. Could you see something right in the, I lost the stent in the left main and LAD. I was trying to push the stent, and inadvertently the nurse also had gone up a little bit positive pressure on the stent, and when we are pushing it up, the balloon got lost and the stent stuck there. Now, again, with no retriever, the snares, we don't have coronary snares easily available there. What is the next line, sir? Dr. Cumberland? Wait a minute. Go back. So
the stent is half in the left main and
half in the
the
left main, and the patient had immediately chest pain, hypotension, bradycardia. He was trying to throw up. He's pulling his hand, and because then and at the first instance we intubated him because he was becoming breathless. He went to LVF, and of course, next slide. Next. Yeah, freeze that. Next. Freeze it.
Yeah.
So really, it was a nightmare. I was alone in a small hospital. I called the anesthetist. At least he could come and at least intubate him, because he was just pulling his hand and getting next slide. So at the outset, I thought nothing else to fall back. At least try to dilate the stent where it is.
I was going to ask you. You've got the balloon in the stent.
Patient had chest pain, lot of bradycardia, ST elevation, hypotension, and luckily my anesthetist was very good. He intubated him, and when he intubated a radial patient, really the radial artery gets relaxed, and I was trying to dilate. Initially, the bulky balloon was not going. Next slide. Next slide. I dilated started with the 2O balloon, dilating because it was not possible to put a 3O. Next slide. and with the jugularly, one wire came out, but luckily I had one wire still in the LED, and one of my associates said that we'll give a femoral route, take a line and try to, if required, an IVP or a guide. Next slide. But when we realized that, we tried, then we dilated left main, but we put another guide you could see there, but anyway, the femoral guide would not be helpful because the wire and the system is on the radial, and we dilated left main. Next slide. And put a wire, and then again dilated left main and into the LED with a 3O balloon. Next slide. There's a lot of waste there. With Dr. Mehta was telling me it's most important that the calcium is very hard. Next slide. We could get a non-compliant balloon, and next slide. Still, it is dilating in an abdominal way. We're not really getting completely lesion being involved there. Next slide. By the time the PP had come up to 90, 100, and then he was intubated. And next slide. We dilated the left main, again, because I thought putting another stent will be difficult. So with 3.5 balloon. Next slide. We got a good flow. We were very happy. The patient is coming back, and the pressure is nice now. Next slide, huge artery. Next slide. So I dilated and put another XL, the biodegradable sirolimus XL stent there, 3018 into the LED now. Next slide. And post-dilated the stent. Next slide. And the overlapping done. Next. Still we dilated with even the LED with a 3 point for the left main. Next slide. Next. Next. Again we did the left main with 3.5 only. We didn't thought 4.0 is very easily available, so we went up to 1820 atmosphere in left main. Next slide. Next. Freeze that. So if you got a result like this and the stent into the left main hanging, and what would you done? Anything different, Dr. Kambalan?
No, I think you did very well. You still had the balloon in the stent. That was the critical thing. And if you let the balloon come back and you've lost access to the stent, then it gets very difficult. If you haven't got a snare or something. The only thing one wonders about, of course, is the circumflex origin, and you've got to look at that carefully. Did you consider getting a wire down the circumflex?
No, yes, I did consider, but the patient was in such a mess, and one of the wire came out, and I thought first to get the LED flow because a very huge artery. Then I thought if there is a greater pinching of the circumflex, I could always reopen through the strut, which is difficult, but I can do something. I just want to show one more. Next slide. Next slide. This was the result, and we have a 8 months follow-up angiogram. That's what I wanted to show you, that we have an 8 months angiogram. While doing a repeat angiogram, it was difficult to put any catheter, Dr. Abi, into because some of the stent strut was in left main. So it was difficult to cannulate that with any Judkins catheter. So we put a guide outside the left main and took the shot. A small catheter. Next slide. Go next. Go next. So this was, I'll show you. Go next. That's it. Next. I should play that. This is what, when the catheter was not getting into because the left main stent was hanging. Next slide. Next. Freeze that. Freeze that. We saw that in 8 months there is minimal restenosis at the ostial circ, but the patient was totally asymptomatic at 5G. That stress was negative, no chest pain, is doing well still about 15, 18 months. Just play that please again, this last slide. This is what 8 months, how the stent of the left main and LED looks like. With little bit of circ, you could see, but with TIMI3 flow. Next slide. This water. Next slide. So this is we had this XL stent put in left main and that biodegradable PLA carrier, which elutes within 6 months. The bioabsorbable polymer doing really well job for the left main and LED. We had a small 70 patient follow-up in this study actually, with comparing the outcomes of the XL stent.
Kalmat, we would have loved to discuss your case. It's an excellent retrieval of this difficult situation. Not the stent, but the situation was retrieved. We have an overseas live transmission, and therefore we are very sorry that we're not able to discuss this elegant procedure that you performed. And thank you very much.
Thank you.